Welcome to session 9 of Oxygen Therapy and Critical Care, the case-based series. Today, we're going to be talking about pediatric considerations for oxygen and critical care. I'm very excited. With us today, as always, will be led by Dr. Papytcho. I think he's having some technical troubles, so hopefully he'll join us in a moment. But with him is Dr. Hope Thury, and they will be leading our session today. So we'll hand it over to them and let Dr. Hope start us out.
Good afternoon, everyone. Welcome to today's session. The topic which has been introduced are the pediatric considerations that we must take into account as healthcare workers in terms of oxygen therapy and critical care. So we'll go straight into our Learning Resource Center for today. My co-host, Dr. Papytcho, will be joining us shortly. Kamal, can you please project?
Yes.
Thank you. Okay. So today we have our patient is a 6-year-old boy, male, who presents with wheezing and an increased work of breathing. So this is our part 9, the considerations for oxygen and critical care. You can scroll downwards, please. Okay. So WHO and literature has it that in terms of the under 5 population, pneumonia is the leading cause of death in this age group. This is by the WHO. So many children die because of the oxygen, because of inadequate oxygenation and critical care. So I'm just going to give you a background of our case. The case for today is our 6-year-old male with no significant past medical history. He comes to the ER with wheezing and an increased work of breathing. His mom says his symptoms started 12 hours ago, and she has noticed that he is less active. He has been less active than usual in the past 24 hours. She also says that for 5 days, he has had a high-grade fever, the highest being 39.3 degrees Celsius. He had a respiratory viral panel. These are investigations to rule out viral causes done. And he has also had a rapid SARS-CoV-2 test. This was 2 days ago. However, both the viral panel and the SARS-CoV-2 tests were negative. So at the time of his investigations 2 days ago, he actually had no respiratory symptoms, but his mom says that his eyes were red and he has redness and swelling of hands and the. She also reports that today his eyes look a little bit more swollen. And mom is kind enough to tell us that their aunt, who lives with them in the same house, had COVID-19 3 weeks ago. However, she was asymptomatic except for anosmia. Kamal, can you scroll downwards? So because you're a good clinician, you decide to get a thorough history of our patient. And in his birth history, mom says he was born at 32 weeks gestation. It was a spontaneous vaginal delivery because of severe preeclampsia. He spent 4 weeks on NICU. However, this was just to feed him and for growth. His past surgical history, he had, Kamal, sorry, just slow down. Past surgical history, he is reported to have an appendectomy in 2019. And then in terms of the social history, he lives at home with his mom, with his parents, his grandparents, and also an aunt and uncle. The aunt is the one who had SARS-CoV-2 in the recent past. His vaccinations, his under 5 vaccinations are all up to date, and they're all except for the influenza shot, which he gets every year, but because of the pandemic, he hasn't received it. He's not on any medications, and there is no history of allergies. Okay, so that is our case background for today. We'll then go straight into we'll straight go into the first section. Kamal, you can just slow down. We're just going to the first session of the first part of our session, which is the medical oxygen supply. In this aspect, we want to understand the sources of medical grade oxygen in our different facilities. And for the purposes of today's discussion, we will be using the World Health Organization guidelines on medical oxygen therapy. So I just want to find out from our participants. Kamau, you can go ahead and go straight to page 17 of our document. But in the meantime, let me just find out from our participants. Feel free to reply in the chat box. What are the sources of oxygen that you know, medical grade oxygen that you know or you have in your facility? So in about 30 seconds, please respond in the chat box the medical grade sources of oxygen that are available in our facilities. Participants, please feel free to throw your answers into the chat box. What are the sources of oxygen, medical grade oxygen, which are available in your facilities? Sources of medical grade oxygen in our facilities. Please feel free to respond in the chat function.
Dr. Hope, should I scroll down this slide?
Yes, please. Let's go to page 17.
17.
17. Okay, thank you. I can see some answers are coming into the chat function. So far, I've got 2 responses. John tells us that he has an oxygen plant in his facility. Michello and Tinga tell us that Michello tells us that he uses cylinders. Tinga tells us that they have oxygen concentrators and oxygen cylinders. Any other oxygen sources that we know? Okay, so we have another response from Edward, who tells us that in Chinsali General Hospital, they have cylinders, an oxygen plant, a concentrator. So thank you very much for the responses, everyone. These are the sources of medical grade oxygen that we use. Kamal, can you take us back to the presentation?
Is it okay, Dr. Hope? This one, 17.
Okay, it's fine, but we can go back to the main presentation.
Okay.
Thank you. So while we get back to the main presentation, just to talk about the sources of medical grade oxygen. Big hospitals would usually have an oxygen plant which uses central piping to deliver the oxygen from the source, and it's then distributed to the rest of the hospital. However, depending on the level of hospital that you are at, you may be using oxygen cylinders, which may be individual standing cylinders, or they may be part of an oxygen cylinder manifold or an oxygen cylinder bank. In terms of the oxygen plants, you can just hold there. Yes, thank you, Kamal. In terms of the oxygen plants, just like Chinsali Hospital is telling us, oxygen plants are usually of 2 types. You could have the pressure swing adsorption oxygen plant. These are the plants which are available here. For instance, in Zambia, this is the type of plant at Levi Mwanawasa Teaching Hospital, at Mainasoko Military Hospital. In the Western world, we also have liquid oxygen tanks. So these are big tanks similar to the ones which we have in the fuel refineries, where oxygen is stored under pressure and it's actually stored as a liquid. So these have to be refilled. These have to be refilled from the source of production. The oxygen cylinders I mentioned could be in banks or manifolds, which are connected to a pipeline into the ward, or you could use cylinders individually on the patient's bedside. However, we also have oxygen concentrators in our hospitals, which generate oxygen from room air. Other facilities may not have may not have access to medical grade oxygen. Okay, so this is just a recap on the sources of the oxygen that we're using in our facilities. So just an update of our patient. We've talked about our little boy. This is a review given the background that we had earlier. So when you check his vitals, his temperature is 39.3 degrees Celsius. His heart rate is quite tachycardic at 135 beats per minute. Blood pressure is 70/32 with a mean arterial pressure of 45. His respiratory rate is on the higher side of 35, and his oxygen concentration levels, his SpO2 is currently 88% on room air. So we'll go to the next aspect of our presentation, which is the actual delivery of oxygen from the source to the patient. I'll ask Dr. Papytcho to take us through this aspect of the presentation. Dr. Papytcho.
Thank you very much, Dr. Hope. Good afternoon to all our participants, and welcome to today's session. Interesting to discuss about pediatric management for oxygen and critical care. So, talking about oxygen delivery, we'll start our discussion with a quiz. So what devices do you have at your facilities that you use for delivering oxygen to pediatric patients? As you are writing in the chat box, I would like to discuss with you the table that we have on the screen. It's really showing us a number of devices that can be used for oxygen delivery. The commonly found is a nasal pump. It said the nasal pump, the flow rate varies from age. For neonates, you give at low flow rate, 0.5 to 1 liter per minute. And for infants, 2 liters per minute. And for the adults, 6 liters per minute. And when you look at it, there's no or minimal PEEP that can be benefited when using nasal pump, especially at low flow rates, except at 6 liters. That is now when you can have a very minimal PEEP that can be benefited when using nasal pump. And as we know, PEEP is useful, especially for pediatrics who've got narrow airway. When they have respiratory distress, they need some little PEEP for them to have their airway a bit more, the resistance being overtaken by the PEEP that you apply to it. The nasal catheter, the difference is not much. In terms of flow, it's similar to that. Just like at 1 liter in infant, it can give you a FiO2, which is slightly larger than the nasal pumps. And the size of the catheter that is required for the infants, it's size 8 catheter. For the nasopharyngeal catheter, the neonates still, they're getting very little flow, and the infant is still at 1. And the deeper it goes, the higher the FiO2. And the size, still the same, 8 French size catheter. Another device that can be used for oxygen delivery is the aid box, the face mask, the incubator, and the normal face mask. So, as you can notice, what matters more is to use what is available at your institution. You might not have all these aid box or face tent, but you only have a nasal pond or a nasal catheter. So the most important thing is to use what is available at your institution. And with time now, you can advise the purchase office of an institution to organize what is needed for better oxygen delivery. So also have to know that the flow limitation is different with age group. As we noticed there, the flow was ranging from 0.5 for neonates and going up as the age was increasing. So high flow is not really needed. When you give it to pediatric or to neonates, there's a risk for causing lung damage or barotrauma or injuring even the soft tissue. Remember those mucosa in the airway, they are just too soft in the neonates. If you want to give very high flow, you might cause damages to the mucosa and then giving more problem. As case updates, when you assess your patient, you found that he has a vital sign as follows: temperature 39.3 degrees Celsius, heart rate of 130 beats per minute, a blood pressure of 72/38, the mean arterial pressure of 49, respiratory rate of 30, SpO2 92% on 4 liters per minute.
Yes, sir.
So because this patient is a bit up, just a bit. Because this patient is on respiratory distress, you would love to have the patient saturation being monitored continuously. So now we are going to discuss the usage of pulse oximeter in pediatric patients. And for this one, Dr. Opp will take us through this. Thank you, Dr. Opp.
Okay, thank you, Dr. Papytcho. So for us, today's session, practice change objective for this session is for us to recognize the safe gauze in terms of pulse oximetry or SpO2 for various pediatric patients and conditions. All this material is available on the Learning Resource Center. Please find time to just peruse and look at the guidelines which have been put in place. However, for the purposes of this,
Sorry, Dr. Go ahead.
okay. However, for the purposes of discussion, we'll look at some statements which represent certain conditions for us to understand the use of pulse oximetry. So here we're going to have a poll. Sarah, can we please run a poll? The question is, which one of the following statements is incorrect regarding oxygen therapy in neonates? Which of the following statements regarding oxygen therapy in neonates is incorrect? The first option, participants, please feel free to choose one of the 4 statements. Which one is incorrect? Or infants who are 32 weeks, who are less than 32 weeks gestation or weigh less than 1.2 kgs or received oxygen therapy should be screened for retinopathy of prematurity at 4 to 6 weeks. Or B, newborn infants requiring oxygen therapy should have SpO2 targets above 88%, but less than 95%. Or C, apnea leads to bradycardia, which further reduces oxygen delivery. Or the last option, D, neonatal ventilatory support should be administered with a bag mask ventilation with 100% FiO2, 100% fraction of inspired oxygen. Okay, is everyone done? Okay, so looking at the responses, thank you so much to everyone who participated in this poll. 80% have chosen option D as the answer, which is incorrect, while 20% have chosen option C, and no one has chosen A and B as incorrect. So just looking at the majority, I think I concur. While A, B, and C are true, option D is incorrect. In terms of neonates, we always have to be careful in terms of ventilation. 100% or pure oxygen to neonates has got deleterious effects. So hyperoxia has got deleterious effects in neonates, which is why children who were premature, either by gestation or those who are very low birth weight, would be screened for retinopathy of prematurity, secondary to oxygen therapy at 4 to 6 weeks. Okay, thank you very much. We'll now move on to the next statement, and I hope that our participants will participate in the next question. Answer true or false. Where pulse oximetry is not available, oxygen should be given to all neonates who have cyanosis or a respiratory rate of more than 70 per minute, or who are too sick to feed. Participants, please answer true or false. Okay, answers are trickling in. Okay, 20 more seconds. Please, let's participate. Answer true or false. Okay, it's time up actually, and only a very small portion, 9% of this group participated in the poll. However, just looking at the answers, we'll go through so that we all understand. Where pulse oximetry is not available, oxygen should be given to all neonates who are cyanotic or who have or who are tachypnic or who are too sick to feed. The answer is true. Okay, so true is the answer. So Kamal, can I have a poll for the next question? Please, participants, answer true or false in the poll. So the question is, in children living at high altitude, okay, Kamal, please, I think you've bypassed the question. In children living at, yes, just there, thank you. In children living at high altitude, that is more than 2,500 meters above sea level, the normal oxygen saturation is lower than for those living at sea level. And the level of oxygen saturation should, as such, of more than 87% or equal to 87% could be used as a threshold for giving supplemental oxygen. Okay, I can see answers are coming. Please answer true or false. Answer true or false. Okay. Answers are trickling in. I'll give it another 20 seconds. Okay, thank you so much for everyone who participated in this poll. Just as before, the answer here is true. Children who live at high altitude have compensated. Children living at high altitude have compensated. And therefore, in terms of the level of SpO2, we have to adjust our trigger. So 87% is used as a threshold. So the answer is true. The next question, let's have a poll for that. Okay. Kamal, can we go back to the presentation? So answer true or false. Children with respiratory disease living at more than 2,500 meters above sea level should receive oxygen therapy if their oxygen saturation is more than 90% as measured by pulse oximetry. So children who have a respiratory illness and are living at high altitude should receive oxygen therapy if their saturation is more than 90%, is less than 90% as measured by pulse oximetry. I think I'll go through that. We could have made an error. Children who have a respiratory illness and are living at less than 2,500 meters above sea level should receive supplemental oxygen if their saturation is less than 90%. So children who are living at less than 2,500 meters above sea level who have an SpO2 of less than 90 should receive supplemental oxygen as measured by pulse oximetry. Okay, I'll give it another 5 seconds. Okay, so the poll is closed and these are the results. I think 71% of our group has agreed that this is true. 29% have said this is false. So the correct answer is true. In this group who are living at less than 2,500 meters above sea level, your trigger becomes different. So the trigger here is about 90% in terms of saturation. So we move on to the next one. Let's have a poll again, Kamal. So for the last question, Kamal, please, let's go back to the last question.
This one, Dr. Hope?
Yes, so the last question, oxygen should always be given intermittently, for instance, giving it every hour or maybe every 2 hours, and should not be administered continuously in order to conserve this precious resource. Oxygen should only be given intermittently, for instance, every hour or after 2 hours, so that we conserve this precious resource. Okay? We'll wait another 30 seconds. Okay, so thank you so much to everyone who's participated. I feel this one was easy because everyone gave their results in a very short period of time. So the answer here is false. We are guided by WHO that oxygen is an essential medicine. And once a patient, you've made a decision to give oxygen, we need to give it continuously. And this should be monitored by pulse oximetry. The decision to remove a patient from oxygen to stop the administration should be guided by our monitoring or pulse oximetry. So the issue of conserving oxygen supplies, that is false. Okay, so we'll move on in terms of our lesson, just to have an update of how our little boy is our little boy is doing. Kamau, can you please scroll downwards? Let's continue with our presentation. So, thank you, just the case update. So our case update, our little boy, he has remained tachypnic, he has nasal flaring, he has retractions, intercostal retractions, but slightly he has improved. So his saturations have slightly improved and they're stable at 92% after you commenced him on oxygen via nasal prongs at 4 liters per minute. So that is our case update. Our little boy is still in distress, but his saturations have improved to 92% on oxygen at 4 liters per minute. At this point, what is going through your mind? What are the possible differential diagnosis of this little boy? So given his history that mom has given so far, the differential diagnosis at this point is still wide. There are a number of respiratory conditions which could present in this manner. So just as the list, this could be an acute exacerbation of asthma. It could be some type of reactive airway disease. He's a little boy. We can't rule out a foreign body aspiration, bronchiolitis, bronchitis. It could be a COVID pneumonia, a community-acquired pneumonia. It could be an upper respiratory tract infection. Maybe he has a vascular ring. It could be congestive cardiac failure. It could be a multi-system inflammatory syndrome in children. It could be cystic fibrosis, a mediastinal mass, a tracheoesophageal fistula, a primary ciliary dyskinesia, laryngomalacia, gastroesophageal reflux disease, or indeed an obstructive sleep apnea. So you can see just from this wide differential diagnosis that there are a number of disease entities which could present in this manner. But let's go on and see how our little boy is faring. So we move on to the next segment. Dr. Papytcho, please take us through the pathophysiology. Dr. Papytcho, are you with us?
Thank you. Kama, please give me an option to be a co-host so that I can have easy access to the system.
Yes, just give me 1 minute, Dr. Papytcho.
Thank you very much. So our practice change objectives for this pathophysiology segment will be to understand and treat pathophysiological condition leading to hypoxemia in pediatric patients. As we may know, the pathophysiology of hypoxemia is long and detailed. To make it easy for understanding, we'll try and go through it using questions, and then to each question, there's a literature that is attached, and then at your own free time, you go and read through for better understanding of this condition. So our first question will be to list 4 diseases of hypoxemia in unit. I'm sure we've interacted with a unit before. We are able to tell what were the diseases that caused hypoxemia to our patients. So in the chat box, please, you can write down 4 diseases that can cause hypoxemia in unit. As our participants are writing down, come on, please, you can click on the link. And you can just scroll the book up or the recommended page. So this is a very interesting book. It got more information on oxygen therapy in pediatric. Everything that you would like to know about pediatric, it's really found in this book. I can see the first answer that coming in, say asthma, ARDS, CTN, respiratory distress syndrome, pneumonia, bronchitis. Wow, these are great answers. Actually, all these answers are correct. So there are a number of causes that can lead to hypoxemia in unit. What is more important here is to be able to identify and diagnose the correct disease so that correct management is taken into consideration for better outcome. Thank you, Kamal. We can go back to the main page. Our second question would be, list 4 diseases of hypoxemia in children. The first was in neonates and now in children. Remember, the age category has changed. So we have to have in mind the pathophysiology that can lead to hypoxemia in children. And remember, we have to categorize the neonates, what group age, the infant, and the children. So now we are talking of children. What diseases can lead to hypoxemia in children? We can still go back to our book, our link, Kamal, as we are writing down the causes on page 15 or 17, page 15. Already answers are coming in the chat box. Pneumonia, PCP, foreign body, aspiration, asthma. I can see we are dealing with genius here. Congenital heart disease, pneumonia, TB, asthma, aspiration. We're really dealing with genius. These are correct answers. So we just have to have in mind the fact that the diseases that you might have in units, you might not necessarily have them in children as well. So based on the age category, the diagnosis may differ. So it's better to know what type of diseases are specifically found in units that might not be found in children, for you to know what could be the issue that's causing the hypoxemia, and then you can easily address it and solve the problem. I encourage you at your own free time, as we said earlier on, access to the LRC, it's free, and then the material is intense and very interesting. Take time, go through these books on all these links that will be shared today or previously. You can have more knowledge about the pathophysiology and other conditions of several other diseases. Thank you, Kamal. We go back to the main. I believe we know the difference between hypoxia and hypoxemia, as we discussed in the previous session. So at this point, hypoxemia will result from decreased oxygen saturation of hemoglobin in the blood. So this can occur in 4 different ways. It can be 1, due to low level of alveolar oxygen or impaired diffusion or impaired oxygen binding to hemoglobin or VQ mismatching. So depending on the ways at which hypoxemia occurs, and intervention should be targeted to sort out the issue. If it's due to impaired diffusion, you see what could be the problem. If it's due to impaired oxygen binding to hemoglobin, if patient is having maybe disorder of hemoglobin or any other bindings to other stuff like a carbon monoxide, you should know what to do so that you free up enough hemoglobin for oxygen binding. If VQ mismatching, shunt, or a dead space, you attend to the problem to improve the VQ match. The third question is to list 2 etiologies leading to low levels of alveolar oxygen. Any 2 etiologies that can lead to a pediatric patient have low level of alveolar oxygen, which will be translated by a poor saturation. We can drop the answer in the chat box. If we've managed to answer those difficult questions, so this one, it's very easy. Anything that can cause low level of oxygen in the alveolar, pneumonia. So in this one, we have to understand that the question here is to ask etiology leading to low levels of alveolar oxygen. What can lead the patient to have low level of oxygen in the alveolar? One could be a patient who's hypoventilating, and then now what could be the cause of hypoventilation? Maybe a baby who came restless, agitated, and then we gave him some sedation for you to cool him down. You gave maybe an overdose of sedation, of diazepam, or any midazolam, or either any sedative drugs that you have, or a patient who was anesthetized and then not fully recovered and then taken out of oxygen. Or as we saw initially in the previous section, when you go to high altitude, you can still also have low oxygen in your alveolar. So there are a number of causes that can lead one to have low level of oxygen into the alveolar. Come on, we can scroll up, please. Another interesting question . Another interesting question is, what type of poisoning leads to ineffective binding of oxygen to hemoglobin? In what setting is this poisoning a risk? We've all seen this before. I can give you a hint. Babies who are sleeping when it's cold, the mother will set up. Correct. I'm seeing a correct answer here already that has been thrown in the chat box. Carbon monoxide. That's correct, John. Carbon monoxide. So carbon monoxide, it's occupied the hemoglobin binding at the place where oxygen should have been. And because the hemoglobin cannot distinguish the difference between carbon monoxide and oxygen, it will accept the binding, and then oxygen will just be circulating and not knowing where to go, making it to be an hypoxic situation, because what will be delivered is not what is needed to the tissue. So we always have to know that patient who comes first, who are locked in a room and then they had a fire or inhalation or smoke, they will come hypoxic because of carbon monoxide that is sitting on the binding place for oxygen. And then the oxygen that you'll be giving at that time might not be able to sit on the actual binding sites on the hemoglobin and leading it to carbon monoxide poisoning. Thank you, Kamal, we can go up. One more question in the pathophysiology, a bit down, Kamal. Thank you, just there, thank you. List 4 causes of VQ mismatch common in pediatric patients. Here it's a matter of understanding what is V and what is Q. In the previous lessons we discussed, we say the VQ mismatch, V would stand for ventilation and Q stand for perfusion. So what can be a cause of an area being ventilated and not perfused, or perfused not ventilated in a situation of a patient, a pediatric patient, and leading to more complications? There are many conditions that can cause this VQ mismatch. Conditions like asthma, congenital heart disease, aspiration, pneumonia, they can all lead to a VQ mismatch. So it's just knowing what is the mismatch that is there on how to intervene for you to improve the initial condition. So let's look at the case update. Come on up, please. So our patient remains tachypnic with nasopharynx and intercostal retraction. The lab that comes back shows that the white blood cell count is 2,000, platelets 110,000, the CRP 30 milligram per liter, ECR 80 millimeters per hour, and the chest X-ray showing bilateral multifocal ground glass and consolidation airspace opacities. There's cardiomegaly and bilateral pleural effusion. With this information, we would like to relook our differential diagnosis. Come on up, please. Thank you, just there. The initial differential diagnosis, we will drop them and focus on the condition that really looks like they can be justified by the actual presentation. So we can look at it as, could it be bronchiolitis? Could it be COVID-19, pneumonia, congestive heart disease, multi-system inflammatory syndrome in children? So after having this in mind, you would like to do another clinical exam. Maybe this can lead you to a final diagnosis. So for this clinical exam, I will request Dr. Ob to take us through the clinical exam.
Okay, thank you so much, Dr. Papytcho. So dear participants, we have seen in the past 3 segments, our little boy who presented to the hospital with a history of some respiratory symptoms, some fever. We have examined him, we have put him on oxygen therapy via the appropriate device that Dr. Papytcho took him to, and what targets we have according to where we are. So in this segment on the clinical examination, to recognize hypoxemia during a clinical exam in pediatric patients, and number 2, how to understand the diagnostic considerations in these patient populations. So what must you think of in terms of hypoxemia when you're dealing with children? So what we're going to do is watch the video, which is posted below. And as we are watching the video, I want us to pay attention to some of the signs which are associated with respiratory distress in children, respiratory distress and hypoxemia in the pediatric population. Kamal, can you please play the video?
So I looked up asthma and it said C,
Something there.
well, it just says C medical, but
Yeah.
you can't.
Okay, so apologies. I think the little boy's face was not shielded. Apologies for that. But in that video, we could see some of the classic signs of respiratory distress and those of hypoxemia. So for you to understand oxygen therapy, the monitoring and respiratory distress, I encourage you to download the World Health Organization Oxygen Therapy for Children manual. This manual is specially designed for healthcare workers and makes recommendations regarding detecting hypoxemia in the pediatric population. We can scroll downwards. Okay, so using this guideline or manual, WHO has made 2 recommendations in terms of detecting hypoxemia. The first recommendation is that 1, the use of pulse oximetry should be used to detect hypoxemia. So pulse oximetry is recommended for determining the presence of hypoxemia and guiding the administration of oxygen therapy for children, for infants, neonates, and children. And the quality of the evidence, this was, even though it was low quality evidence, this is a strong recommendation that is there. The second recommendation from the WHO manual, Kamal, please scroll downwards. The second recommendation is that when clinical signs are being used in children, so for instance, if you are in an environment where the use of pulse oximetry is not available, so when pulse oximetry is not available, clinical signs can be used to detect hypoxemia in children. So for you to detect hypoxemia, you must look at certain clinical signs. So some of these signs which will help determine or guide oxygen therapy are 1, the presence of central cyanosis, nasal flaring, the inability to drink or feed by a child. This is when they are in respiratory distress, grunting with every breath, a depressed mental status. For instance, your child could be drowsy or they could be lethargic. So this is a strong recommendation by WHO. In the second part of the second recommendation, in some situations, depending on the overall clinical picture of the child, children could have following less specific signs, but they may still require oxygen. So please distinguish between part A and part B. In part A, most of the signs that we're looking at are focused at the respiratory system, but in part B, these are other clinical features which may be less specific, but the child still requires oxygen. Kamal, please scroll downwards. So here, your patient could have severe, I think you have skipped it, Kamal. So in part B of this recommendation, your child could have severe lower chest indrawing. So this is your subcostal recession. They could have a respiratory rate of more than 70 per minute, and they could also have head nodding. So just as a reminder, why are we focusing on the clinical? Why are we focusing on the clinical signs? You may wish to use these clinical signs where pulse oximetry is not available. So for instance, what causes grunting in children? So grunting helps the child to generate a PEEP, and we know that PEEP is the pressure which is needed to prevent the alveoli from collapsing at the end of respiration or expiration. So grunting, especially in the under part 2A, helps the child. With every breath that they take, it helps them prevent the alveoli from collapsing. In terms of head nodding, what causes the child to have head nodding? So for most of this can be attributed to the use of the accessory muscles as the child is breathing. So these are some of the guidelines or the recommendations that the WHO has put. So let's continue with our presentation. So here I have a question for you. What are some of the major challenges that you have faced when you're examining a child who is in respiratory distress or who has hypoxemia? What are some of the challenges, the major challenges that you may encounter as you examine patients in this population for hypoxemia? If you have any responses from your personal experience, please feel free to drop them in your chat box so that we can all learn.
Sorry, Dr. Hope, just give me 1 minute.
Okay, no problem. So dear colleagues, what are some of the challenges that you have encountered as you attend to a patient who is hypoxemic in the pediatric population? What are some of the challenges with this patient group? Okay, John tells us that irritability is a challenge that he encounters, and I do agree with you. The child may be so irritable and they may not allow you to get near them. Any other responses from the other colleagues on this call? Okay, so Gael tells us that measuring the respiratory rate is quite a challenge because it's quite quick and it may be superficial. So that is a challenge in this patient group. Anyone else who has encountered challenges? Okay, so thank you for those two responses. So one of the aspects that you must think about is that for a lot of us, we don't deal with children every day. So we're quite unfamiliar with dealing with children, and worse off a child who is very sick. So it's difficult to detect these fine clinical signs that a child may have. So it may be difficult for you to detect a central cyanosis. It may be difficult for you to check the tongue. The child may not allow you. You may actually have to use other gadgets. For instance, UV light. Pediatric patients, they also can't talk. So for you to say, I'm going to see if they're completing a sentence, that may not be possible. So pediatric patients may not be cooperative, they may be crying, and we don't understand some of the feelings that they have. So those are some of the challenges in this patient group. Can you please scroll? Okay, so I'm going to give you a case update. Let us just see how our patient is doing. So, Kamau, I think you missed the vitals. Can you scroll up a little bit? Just scroll up a little bit. Yes, so in terms of the vital signs, how is our little boy doing? When you check the vital signs, you find that the temperature is 38.9 in the axilla, the pulse is 133, respiratory rate is now at 30, the blood pressure is 77/38 with a MAP of 51, and the SpO2 is now at 92%. Then these are some of the findings, the pertinent positives on your physical examination. You'll find that the weight is 20 kilograms. The overall general condition, he's ill looking and drowsy, but when you arouse him, when you shake him, the patient is arousable. It's distress. Eyes, he's got bilateral conjunctivitis bronchitis, but has no discharge, and there's no jaundice. There's some mild periorbital edema, but there's no erythema. He's got nasal flaring. The veins in the mouth are tacky, slightly swollen, with a strawberry red tongue. Examination of this chest, there's an increased work of breathing, and he's using accessory muscles of respiration. The lung fields, he has some crackles bilaterally in the bases, and intermittently he is wheezing with a prolonged expiratory phase. However, there's stridor, there are no rubs, and the air movement is good bilaterally. In the cardiovascular system, you find that I think in the cardiovascular system, everything is okay, except that in S3, there is a gallop rhythm. There are no rubs. And however, you are able to detect pulses in all the extremities, even though it's slightly weaker in the femoral pulses. His capillary refill time is increased. It is more than 3 seconds. So that is our cardiovascular assessment. In terms of the abdomen, the lower edge of the liver is palpable, 4 centimeters below the costal margin. A scratch test reveals that the liver span is actually at 9 centimeters. He has non-pitting edema in the hands, and there is no cyanosis there. His skin, there's some palmar erythema bilaterally, no rash, with a poor skin turgor and mild tenting. So that is how our patient is doing. So now we'll take a pause to ask ourselves some of these questions. What are emergency signs when we're dealing with the patient? Which are the emergency signs which we can see already from our patients, which require immediate intervention or time critical care? So we're going to review this table, which tells us some of the emergency signs which our patient has depicted. So as usual, feel free at your own time to click onto the reference material, which is the WHO Oxygen Therapy Manual. We'll look at it, feel free to look at it at your own time. But here is a table which has been pulled out from that manual, which tells us the emergency signs or time critical signs that we must particularly pay attention to as healthcare workers. So emergency signs are those signs which once found require for us to intervene. Otherwise, if we do not intervene, this is a patient who may deteriorate and progress into a respiratory failure or death. So obstructed or absent breathing, severe respiratory distress, central cyanosis, any signs of shock. So these could be cold extremities, an increased capillary refill time of more than 30 seconds, tachycardia, weak pulse, or an unmeasurable blood pressure reading. If your patient is in coma or has a markedly reduced level of consciousness, if they begin to convulse, or any signs of dehydration, especially in a child who has diarrhea. So signs of dehydration are lethargy, sunken eyes, a slow return after a skin pinch. So any of these two signs indicate severe dehydration in a child who is losing fluids. So we must intervene immediately whenever we come across an emergency. So at your own time, let us look at our boy and see which signs that he had. Did he have any evidence of emergency signs? What are some of the interventions that you must put in place? Very important for us to consider. Kamau, can we move on to the next aspect? Okay, so I think figure 5 is just showing us a healthcare worker who is attending to a little boy, and you can see that the boy is on continuous pulse oximetry, even as his mom nurses him. Kamau, can we scroll down? Okay, so we come to one question, and this question is something which all of us must consider. How can a healthcare worker distinguish between respiratory distress and respiratory failure? Is there any Is there any distinguishing feature when we mention that a patient is in respiratory distress or respiratory failure? If you have any answer, please drop it in the chat box. What is the difference between respiratory distress and respiratory failure? Okay, so in the interest of time, I will just give my own, in the interest of time, as you drop your answers, I will just give my own take. So in terms of respiratory distress, these are some of the signs and we talked about earlier. So here, your child, while they're in respiratory distress, they'll still be compensating. The SpO2 could be low and the carbon dioxide could be high. But as they progress to go into respiratory failure, the levels of carbon dioxide begin to increase markedly. They stop compensating. So the respiratory rate, instead of high, it may actually start to slow down. And as this slows down, as the levels of carbon dioxide increase in the blood, you'll find that your patient progresses into failure. So the carbon dioxide, the increase in carbon dioxide will cause some CNS changes. So for instance, the level of consciousness will actually begin to drop. So your patient will become lethargic, they may actually start to convulse, or they could become unconscious. So eventually they may stop breathing. They may actually have collapse, stop breathing, and go into cardiac arrest. So it becomes very important for us to avoid reaching the stage of respiratory failure. So time critical care, when we identify a patient to be in respiratory distress, is very important. At this point, I'm going to ask Kamal to break us into two groups, and we will look at the therapeutics and some of the interventions. Would quickly discuss in about 5 to 10 minutes the therapeutics and some of the interventions when we have a child who is in respiratory distress or a child who is progressing to respiratory failure. Kamal, can you break us?
I have the breakout sessions ready. So you guys will have just a few minutes in your breakout rooms, and then we'll come back and discuss. So you should see an invitation pop up on your screen to join a breakout room. And if you could just click join, half of you will go to breakout room and half will stay in here.
You did not select the auto move. There is an option by that everyone can automatically join that group. No issues. We can't change right now.
Oh, I filled. Well, Dr. Papytcho, you could go ahead and get started if you'd like.
I'm still waiting for acceptance.
Shara, Dr. Papytcho is not assigned for any group.
Dr. Papytcho will stay in this main session and lead a group here in the main session. And then Dr. Hope will lead a group in room 1.
Okay, so I stay in the main session.
Yes, you'll stay in the main session. So you can go ahead and start.
Okay. Is it running already?
Yes.
Okay, so welcome to group 1. I believe this is group 1. In group 1, we are going to discuss quickly over few point. And the point that we'll discuss will be like to list 3 treatment guidelines to alleviate disorders that can lead to increased wake of breathing. So what are the conditions that can lead to increased wake of breathing? Sarah, you can help? How many participants do you have in my room? Come on, how many
Doctor,
participants do you have in my room?
You have nearby 12 people in your room.
Or 12 in my room? Okay, because I'm not seeing any here. Those in my room, please be a bit active. This is a breakout session. Who's volunteering to be our rapporteur? Who's the rapporteur for this breakout session? Who's volunteering? Okay, because there's no volunteer, I'll take it up because we are running out of time. So I was saying, in this group, we are going to discuss about techniques that you can do to resolve and increase wake of breathing in a pediatric. So for that matter, for you to know what to do, you first have to identify what is the cause, what is the condition that is leading to increase wake of breathing. Depending on the cause, then you will know what to do. It could be an increase intracranial pressure. So if there is increased intracranial pressure, then what should you do? You have to make sure that you are fighting hypoxemia, you are fighting hypercarbia, and hyperthermia. Those 3 situations, those 3 conditions, they can easily lead to increased wake of breathing. You fight hypoxemia by making sure that your patient is well ventilated. If there's need, you intubate them and give them good ventilation strategies. Same for hypercarbia and the hypoxemia. If the patient is so hyperthermic, try to cool them down by giving ideal antipyretics so that you sort out the issue of temperature. If it's neuromuscular disease, definitely the patient will need a ventilation support. And thirdly, if the patient is in overdose, based on the condition or on the drug that they took to cause the overdose, you might need to give an antidote if it's available. If not available, then you have to give a supportive type of management until the condition of the patient improves. Or if you cannot do this, you can send the patient to an area where they can give a better support, the nearest hospital in the area. Another point that we would like to discuss in this group is the intervention that you can do to alleviate disorders of lung tissue diseases. So like if the patient has pneumonia or pulmonary edema, or the patient has ARDS, what can you do to improve condition of that patient? By alleviating the disease or the disorder, basically what you mean is to improve the condition of the patient. So in such situation, like in pneumonia, you will try to find out what could be the cause of that pneumonia. Is it a bacterial pneumonia? Is it a viral pneumonia? or any type of pneumonia, either fungal or any. But mostly in children, we can have a bacterial pneumonia where you might give an antibiotic that is effective in your area, or that can be directed by the lab, or you might go further by giving a type of ventilation support. Despite you putting the patient on antibiotic, maybe for the first few days, patient might not be responding immediately by having a better oxygenation or saturation. So they might need a form of respiratory support, either a CPAP or a BiPAP. They might also need some bronchodilators based on the clinical assessment of what you find. In pulmonary edema, as one of the cause of lung tissue diseases, you might also need to support the patient with a type of ventilation. And we know the ideal mode of ventilation in pulmonary edema is a non-invasive mode. So when you put that, there should be a good PIP. Yes, please.
Time is just about up, so everyone should be joining back in a few moments, just so you know.
Okay. Are we all back?
Yes, we are all back now.
So, Dr. Hope, I can start with my group.
Yes, please.
Okay. In my group, I didn't get anyone who volunteered to be a rapporteur. So I was discussing with them, and especially that I wasn't able to see exactly who a member of the group. So I will go through the few lines that were to discuss in our group. Among them is to list 3 management guidelines to alleviate disorders that will lead to increased work of breathing. So in such case, when patient has a high work of breathing, I think what is important is to know the cause. What is leading to the increased work of breathing? For example, if it's increased, or if it's like high neuromuscular blockades, patient who's coming from theater was ventilated and paralyzed, they might have poor reversal. And when you extubate and you leave them free, they might show increased sign of breathing, increased work of breathing. So those who need ventilation support, that is the best treatment that you can give to them until they completely reverse. And the other one can be in case of overdose poisoning. An antidote can be given, like if it's opioid that was given for sedation, you can give antidotes, naloxone, or if it's benzodiazepam, you can give fumazine, depending on if you have it. If you don't have those antidotes, continue supporting until when the drugs is purely metabolized, and then patient will recover and go back to normal ventilation, and the work of breathing will reduce. Another point that we would like to mention, the third one, is when there's increased ICP, increased intracranial pressure. When there's intracranial pressure, you would like to avoid hypoxemia, you would like to avoid hypercarbia, you would like to avoid hyperthermia. By avoiding these points, we are purely leaving the patient in a better condition, and then the breathing will be smooth and better. The other point that we'd like to discuss is the interventions to alleviate disorders of lung tissue diseases. So in the lung tissue diseases, it can either be the tissue itself that is diseased, or there's something else that has gone into the tissue, sitting in the wrong place, like somebody pulmonary edema, whereby now it's the water occupying the alveolar lining. In such case, the easiest to do is to ventilate the patient, and the best mode of ventilation is non-invasive ventilation, whereby you give enough PEEP. You might also need to give enough diuretics so that you push patient to release enough fluid that they've accumulated and releasing the alveolar from being occupied by the fluid that is there. In terms of pneumonia, if it's bacterial pneumonia, you put the patient on antibiotic. Despite putting the patient on antibiotics, sometimes they don't respond there, and then you might force to use a support like a non-invasive as well, a CPAP, or if it's not responding, you might end up giving an intubation, you go for invasive mode of ventilation, also use of some steroid or bronchodilators based on the clinical assessments that you find on the patient. Thank you, Dr. Opp. This is what we had to discuss in our group.
Okay, thank you so much, Dr. Papytcho. I'll ask Charity. Charity, are you still on the call?
Sorry, try unmuting yourself now, Charity.
Hello, I'm still with you.
Thank you. Go ahead. Charity, you can go ahead to talk about the two aspects that we discussed. Okay, Charity, I'm not getting any response from Charity. Julius, would you want to come and assist Charity?
Yes, I'm ready.
Okay, please go ahead.
Okay, so
Hello?
I think Charity is back. Okay, so the first one we discussed was about our experiences when it comes to airway obstructions, the causes of airway obstructions in children. And we identified three major causes. The first one is foreign bodies, such as beads. Then the second one, we discussed about infections, where epiglottitis, croup, acute viral infections are some of the things we discussed. We also discussed about anaphylaxis, which is also another cause of airway obstructions. Then the second topic that we discussed was about the interventions we can put in place to curb these obstructions. When it comes to infections, we can treat with, or we treat with antibiotics if it is bacterial infections, and then you treat accordingly, according to the organisms that you have identified. Then you nebulize you nebulize in terms of anaphylaxis, and then if it is foreign body, you try to remove it. But the major thing is to identify the major cause or what is actually causing the obstruction, and that will lead you to the solution to provide. And so the final one we discussed about some challenges, which is about the differences in children's airway makeup. Thank you. That is what I was able to write.
Okay.
Thank you very much.
Charity, do you want to add something?
Hello?
Hi, Charity, do you want to add anything?
Though I didn't get the first part, I was just able to get the last part, but I can remember we discussed some of the things that can cause upper airway obstruction, where we talked of infections like croup, epiglottitis, as well as the laryngotracheal conditions. And we also talked about the anaphylaxis and some of the interventions that can be done, and also foreign body, which I heard him explain about that. Then the last part, I was able to get it where he was talking about some of the effective interventions that can be done to relieve the airway obstruction, such as this depends on the cause. For example, if it is a foreign body, you need to assess and then try to remove the foreign body. If it is due to conditions like croup, you can try to nebulize with adrenaline. That's all that I got.
Okay, thank you very much, Charity. So the last part, when we're looking at the thanks. The last part, when we're talking about the considerations in terms of the pediatric airway, colleagues, let us remember that for children, their airways are so small and narrow compared to an adult. So if a child has got a secretion, if they have a foreign body, only edema in the airway, the change in terms of the width of the airway will be markedly increased. So any change, any small change in the radius of the airway causes an increase up to 16-fold times, so R to the power 4 in terms of the resistance of breathing. So it becomes very important for us to give particular care when we're dealing with children who have airway obstruction. Children, as I mentioned, a lot of us are not familiar or are not comfortable to deal with tiny children because of some of these challenges. But once we understand the physiology, the respiratory physiology, and some of the airway or anatomical differences between children and adults, we'll become more comfortable. So for all of this material, which has been presented today, I encourage all the participants on this call to visit the Learning Resource Center so that you can go into detail for some of the aspects that we have discussed today. I also encourage you to download the WHO manuals on oxygen therapy in children and also oxygen therapy monitoring. I'll hand over to Dr. Papytcho to give his summary statement. Dr. Papytcho.
Thank you very much, Dr. Opp, for the wonderful discussion you had in your group. Come up, please. Can we go to the main screen, the sharing screen?
This one, Dr. Papytcho?
Down, please. Scroll down or up. No, then let it be down. Again. We go. Again. All this we've discussed already. Okay, just there. So we just want to make more, to add up on the recommendation done by Dr. Off to say, for more information, you can go on the website and get more material for you to read. The sharing of this information is free. You can access it free. Just register if you're not registered yet. Download as much as you can for your personal readings and personal information and share it with other colleagues. It was nice to have you on this call. And we are very grateful that you happened to join us. We hope that you'll be again available for the next meeting, which will take place in exactly 4 weeks, meaning in October. As at for now, I'll hand it back to Sarah for final words.
Sorry, Sarah, I'll interrupt you. So
Yes,
dear
please.
participants, just before Sarah speaks, I encourage you to look at the final diagnosis, what the problem was with our patient. It's quite interesting, and it's a phenomena that all of us need to read and learn about. I won't give it to you, but visit the Learning Resource Center so that we all know what was wrong with our little boy today. Sarah?
Yes, thank you, Dr. Hope. And thank you, Dr. Papytcho, for this excellent session. It was very informative. Kamal, are you able to share those last housekeeping slides? So in the chat, I just shared a link to the Learning Resource Center. If you would like to access everything that you saw today, it can be seen in the Learning Resource Center. So you have access to the presentation, to all of the supplementary materials, etc. It's all on there. You can also join our WhatsApp group. Here is the QR code if you'd like to join. The session recording and the links to the Learning Resource Center and all the materials will be emailed to you after the session. And there's also a link to access a certificate of participation if you would like one of those. Can you go to the next slide? Come on. Perfect. Please join us for our next session on October 21st. We'll be talking about obstetric considerations for oxygen therapy, session 10. And if you have any questions, please email echo@assistinternational.org. And thank you so much to Dr. Hope and Dr. Papytcho for leading today's session. It was excellent. Thank you to Echo India for supporting this session, and to Assist in Stanford for helping put this on. Again, if you have any questions, please reach out and ask us, and we'd be happy to help. Otherwise, we will see you next month in October.
Bye-bye.
Bye, everyone.
Bye, thank you.